So to start off, we frequently hear this question, when should I worry about a child's appearance and particularly an infant's appearance, and what should be done about it? Over the next 10 minutes, I hope that I'll be able to give you some idea about how to answer that question. So with regards to normal skull development, there's two processes that are going on. The brain is growing, and as it grows, it's pushing on the overlying skull, particularly the skull of the calvarium, or the upper part that encases the brain. Obviously, as those plates moved outward, gaps develop between the plates, and the growth is occurring in that area to close those gaps back. The dura is the periosteum for the inner table of the skull, while the scalp provides the periosteum for the outer table. The tensile forces that the dura applies on those bony plates as they're displaced stimulates the growth that then closes the gap that develops with the displacement. And that's the force that actually leads to the new bone growth that closes and keeps those suture lines thin. The calvarium, or the upper part of the skull, has 5 bony plates. There are 2 frontal plates, 2 parietal plates, and 1 occipital plate. Those plates are joined by suture lines. The metopic is between the 2 frontal plates. You have 2 coronal sutures, one on either side between the frontal plate and the parietal plate. You have a sagittal suture in the midline at the top that join the 2 parietal plates, and then posteriorly you have the 2 lambdoidal sutures that join the parietal plate to the occipital plate. With regards to face, facial bones are attached to the base of the skull. The base of the skull does not have the displacement to the extent that you see in the calvarium, and for that reason, it grows more slowly. It does not have the tensile forces being applied to it that one sees on the calvarium. Since the facial bones are attached to the skull base, its growth, which is lagging the skull base growth, which is lagging the calvaria growth, will also lead to a slower development of the facial structure. And this is what accounts for the typical appearance of an infant with a very large calvarium and a disproportionately small facial bone structure. There are 2 broad categories of skull abnormalities that we deal with. First is deformational plagiocephaly. You all are aware of this. It has a very high prevalence, up to 45% by the time infants are 2 months of age. It's felt that it can be due to both in utero forces and also positional forces after the baby is born. In utero occur in about 18% can be seen in about 18% of newborns, according to one study that looked at 201 newborn infants within 36 hours of their birth. Positional, as I said, is going to be 80% plus of the children that exhibit positional plagiocephaly by 2 months of age. Craniosynostosis, on the other hand, is rarer. Its prevalence is about 1 in 1,400. The majority of the cases are sporadic. But approximately 30% of cases will be familial with an autosomal dominant type of inheritance. I'm sorry, 8% will be familial with an autosomal dominant inheritance. With regards to craniosynostosis, about 30% will be syndromic or associated with other abnormalities in the body, whereas nearly 70% will be non-syndromic and not be, and will occur as isolated single suture synostosis. A small percentage of the craniosynostosis will be secondary to other conditions, some of them being rickets, hematological disorders, mucopolysaccharidoses, hypothyroidism are some of the conditions that can cause secondary craniosynostosis. There are categories to describe the craniosynostosis. When examining these children, it's best to look from the top down onto the vertex of the skull. And you can see the normal head or the various craniosynostoses or the deformational plagiocephaly all have characteristic shapes. One does not need to get x-rays or CAT scans on children that are being evaluated for skull abnormalities. All one needs to know is the patterns that are characteristic for the various conditions. We prefer that the x-rays not be done because it's not uncommon as you start to get into decisions about treatment, particularly in craniosynostosis. One wants to get CAT scans or 3D CAT scans with the attendant radiation exposure. So it's ideal not to have radiation exposure before these children are sent to a craniofacial center. To go through them, the trigonencephaly or triangle-shaped head is due to fusion of the metopic suture. The brachiocephalic or broadly shaped head is due to bilateral craniosynostosis. Anterior plagiocephaly and posterior plagiocephaly are due to unilateral fusion of either the coronal in the anterior case or the lambdoidal in the posterior case. And then the boat-shaped head or scaphocephalia is due to fusion of the sagittal synostosis that causes this typical deformity. These are all in contradistinction to the deformational plagiocephaly. So it's quite easy to differentiate the craniosynostosis from the deformational plagiocephaly. And this is how it's done. Craniosynostosis, it progresses from a single point and it prevents normal displacement, thus normal growth of the skull. So it impedes growth. For that reason, on the ipsilateral side of the coronal synostosis, you're going to have less bone volume than you will on the contralateral side. So if one's talking about a posterior plagiocephaly or an anterior plagiocephaly, the deformation will tend to look trapezoid when viewed from above. In positional or deformational plagiocephaly, there's no limitation to the growth. It's simply displaced. So if one is laying on the back, it's preventing growth in the outward direction in the occipital area. And for that reason, the growth is displaced to the ipsilateral frontal area and the contralateral occipital area, and you end up with a shape that emulates a parallelogram. So quite easy to differentiate the two of these. Sometimes there can be some concerns about the about flattening in the occiput, and it may not be completely clear about whether or not it is a plagiocephaly. Most cranial facial centers can differentiate the two, and we're happy to do that. But typically, when a child comes into your office with an abnormal head shape, or the parents are concerned about the shape of the child's head, you can just simply refer to the pattern chart and look from above, see what pattern you have. And there's a very simple question. If it's a parallelogram, it's deformational plagiocephaly. If it's anything else, it's probably a craniosynostosis, and that child should be referred to a craniofacial center. And the reason I say that is not just because of the appearance of the child and the fact that it's not going to improve over time, that there's a frank fusion there that's preventing growth. There are other associated problems, particularly when the fusions are anterior, that one needs to consider treating. So they can be ophthalmologic due to a exophthalmos secondary to a small orbit, or they could be problems with lid closure that can lead to keratitis. It's important that the treatment get picked up early so that these things are dealt with. The other issue is many of the anterior craniosynostosis are associated with elevation in intracranial pressure that can interfere with cerebral blood flow, and a brain that is poorly nourished in the neonatal period is a brain that's at risk for developmental anomalies. So that's the other concern that is present with these children. So to reiterate, it's quite easy. The child comes to you because of a question of the cosmetic impact of a skull abnormality. You determine whether you're dealing with a deformational plagiocephaly, which will over time improve. And the greatest risk you have there is for a cosmetic anomaly, but the volume of the head is going to be normal. So you don't have some of the secondary consequences of a craniosynostosis. That's in contradistinction to these other head shape abnormalities that do have associated risks, should be referred to a craniofacial center early, and surgery may be in the offing if it's severe enough or there's concerns about some of these secondary complications. So I hope I've given you some idea about where all this sits, and how to differentiate a child who has a safe skull anomaly versus a child that is probably going to require treatment. I think I've gone over my speaking time, so we'll have to go to Elise Uppel. Elise is a nurse practitioner, and she's going to discuss with you what these children will encounter when they come for an evaluation, and how they will be handled if and when they need to be admitted to the hospital for a surgery. Elise?
Hi, everyone. I am Elise. As Dr. Abbott said, I am the craniofacial nurse practitioner at Montefiore. And I'm going to talk to you a little bit about diagnosis and management of craniosynostosis. Okay, so first we're going to start with a little bit of history. So craniosynostosis affects approximately 1 in every 2,000 live births. It was first described by the famed German pathologist Rudolf Virchow in 1851. And Virchow taught us that skull growth is perpendicular to suture lines. And that's kind of represented by the picture here. You can see these black lines are all the suture lines we're looking from above. And the arrows represent the direction of skull growth. So Craniosynostosis occurs as an isolated condition or as part of a syndrome, and we classify it as either syndromic or non-syndromic. So with syndromic, there are three most commonly associated syndromes, and those are Crouzon, Apert, and Pfeiffer syndrome. Non-syndromic can be characterized into simple, which is one affected suture, or complex, which is multi-suture synostosis. And then in terms of morphologic phenotype, sagittal synostosis is the most common type, and it's seen in 40 to 55% of non-syndromic cases. Now, the syndromic versus non-syndromic portion of this is really important to distinguish. They're two very different types of patients, and it's really important for families to understand this before they start doing their online research. They're Googling that syndromic cases tend to be much more complex. They tend to be multi-suture fusion, and bicoronal is the most common of those. So I know that Dr. Abbott went over this as well, but just to reiterate, so on the forehead here, you have the metopic suture. Coming down the sides, you have the right and left coronal sutures. Down in the AP direction, you have the sagittal suture, and then posteriorly, you have the right and left lambdoid sutures. And as a reminder, all these sutures do eventually close, normally later in life, but the issues occur when they fuse before the brain is done growing. So as we know, craniosynostosis is the premature fusion of one or more of these sutures. And in light of Virchow's law, skull deformities in craniosynostosis occur as a result of cessation of growth across prematurely fused sutures, with compensatory growth occurring along unfused sutures in a direction parallel to the affected suture. So you can see here how the skull grows when each suture is fused. So here on the left, we have metopic synostosis, and you get this triangle shape or keel shaped deformity that Dr. Abbott was talking about. Here you have bicoronal synostosis. So the head is unable to grow in the AP direction, so it grows laterally where these arrows are going. Here you have unicoronal synostosis, and again, you get this trapezoidal shape. And here's lambdoid synostosis, another trapezoid. And then finally, we have scaphocephaly, which is when the sagittal sutures fused and the head can't grow laterally. So it grows in the AP direction, and the head becomes very elongated like this. And like I said, that's the most common type. So here's a CT scan of a normal infant skull. And here you can see in the middle, there's a wide open anterior fontanelle. And then coming off of it, you can see the sagittal suture, you can see both coronal sutures and the metopic suture, and all of those are patent, they're wide open. Here we have a CT of a skull with a fused sagittal suture. So just as a reminder, when the suture's fused, you can't get growth perpendicularly to that suture. So here the skull can't grow laterally, so it has to grow in the AP direction. And this is what this kid would look like clinically, with a really elongated head. You have some bossing here. This is what they present as to us. This is CT of a kid with a fused metopic suture. Again, you can see the sagittal sutures open, the coronal sutures are open, the lambdoid sutures are open, but here's the fused metopic in the front here. And just a note about metopic synostosis, there's actually a pretty big spectrum of severity. Some are really mild cases where we don't actually do anything to treat it. And the next kind of level is where we just shave the metopic ridge. And then for the most severe cases, we do our full cranial vault remodeling. And this is what this kid presents to us as. So again, synostosis of the metopic suture, and you can see the keel-shaped deformity of the forehead. He's got a prominent ridge in the midline. He's got a little hypotelorism here too. And this is a pretty severe case of metopic synostosis. So you can see a slice of the CT over here. His metopic suture is definitely closed there, and then his triangular or keel-shaped deformity here. So I want to talk a little bit more about deformational versus synostotic plagiocephaly. It's really crucial to distinguish between the two. And I know as pediatricians, you guys probably see a lot of deformational plagiocephaly, particularly since the Back to Sleep campaign. So the reason we need to distinguish between the two is that treatments are very different. So it's surgery for synostosis versus non-invasive measures like helmets or positioning for deformational plagiocephaly. So one of the things that's really helpful is to stand from above the patient and look down at the overall head shape from above. So again, this is the graphic we like to use to show, to differentiate between the two. So on the top here, you can see that this head shape is in a parallelogram. So it's what we call symmetrically asymmetric that you get with positional plagiocephaly, and everything's twisting in the same direction. So you get this parallelogram. And then on the bottom here, this is a unicoronal synostosis, which gives more of a trapezoidal shape to the head. So looking further into differentiating between the two on physical exam, with deformational plagiocephaly, everything's moving in the same direction. So while there are some subtle asymmetries in the face, in general, there's much more twisting with craniosynostosis. You can see deformities from the eyebrows down. The ear on the side of the fused suture is often displaced towards the fusion. So in the case of this graphic here, it would be displaced anteriorly towards the left side because that's the suture that's fused. And then the tip of the nose and the chin actually deviate contralaterally. So they go towards the opposite side of the fused suture, and the eyebrow and orbit on the affected side appear elevated. So this is a great example of a kid with unicoronal synostosis. You can tell her right eyebrow and orbit appear much higher than her left side, and this is called a harlequin deformity, and this is pretty characteristic of unicoronal synostosis. And you can also see that her nasal tip and her chin are actually deviating towards the left, so the opposite side of the suture that's fused. So while the upper third of the skull is twisted towards the right, you can see that pretty well on CT here, the lower 2/3 are actually twisting left. So you can kind of think of that as a corkscrew. And again, that's pretty characteristic of unicoronal synostosis. So that's a good way to tell the difference between deformational and craniosynostosis. So here's a little flow chart of kind of how we take these patients. So if we think based on clinical presentation that somebody may have craniosynostosis, we'll get a CT scan to see if there are fused sutures. And if there are fused sutures, then we'll do a cranial vault remodeling. If based on the exam, we think that it's more likely deformational plagiocephaly, they would have open sutures in that case, and no surgical intervention. There may be helmet therapy, there may be other non-invasive interventions that we can do for those patients. So why do we treat? Untreated craniosynostosis can lead to deformities of the cranial base, mid-face defects, dental malocclusion, and of course, issues with self-esteem. So the treatment for deformational plagiocephaly. So the first things that we tend to recommend are increasing tummy time, repositioning frequently off the flattened area when lying down. So there are pillows that can help with that. Sitting upright, being held, just any position where they're not laying down flat on their back. And then of course, physical therapy if the baby has torticollis. And kind of as a last resort, we recommend a helmet. Ideally, they'll start at around 3 to 6 months old. It can be done when they're older, but it usually takes more time to correct. They have to wear the helmet 23 hours a day, and the average treatment time is 3 months long. So it is definitely a big commitment on the parent's part, and regular visits within there. So the treatment, on the other hand, for craniosynostosis is surgery. So we do a cranial vault remodeling, which involves reshaping and redistribution of existing cranial bone to create an expanded cranial vault. Ideal time is 6 to 8 months old, and operating time is 3 to 4 hours. The benefits are that the results are immediate, as you can see from this photo here. This is a pre-op on table and post-op on table, so you can see it immediately, and there's no need for additional surgery. This is it, it's just this. So pre-op, we think about a few things. What type of craniosynostosis is this? Is it syndromic? Is it non-syndromic? Is it associated with other anomalies? Is there potential for increased ICP, OSA, airway issues? Will they require any other tests before going into surgery? And we also want to look at baseline labs. So typically, unless there are other issues, we usually just will draw a CBC and type in screen. And post-op care. So they're always admitted to the PICU for close monitoring for the first night after surgery. Typically, they'll be sent down to the regular floors the next morning, and they'll stay there for about 3 more nights. By the time they go back home, they're essentially back to baseline. We usually just send them with Tylenol for pain control, and they do really, really well with that. They do have a large head dressing in place post-op, which you can see in this picture here. And we take that off before they get discharged, and they go home with typically just steri strips over the incision. There's no helmets or anything required post-op, no restriction of activity or special precautions. There is fairly significant periorbital edema occurring particularly in the day or two following surgery, but it gradually resolves itself. So it's just reassurance for the parents that things will get back to normal. We do like to follow them closely at regular intervals. We're looking at the incision site as well as the overall head shape over time. So we will see them at 2 weeks, 6 weeks, 12 weeks, 24 weeks, 1 year. And then we like to see them annually up until they're an adult. So in summary, it is important to distinguish between positional plagiocephaly and actual craniosynostosis. Not all asymmetric skulls need surgery. I think that's the big takeaway here. For those that are positional, helmets are not always the answer. They require a huge commitment. For those that have craniosynostosis, it's really important to differentiate syndromic versus non-syndromic and to emphasize to the families that these are two very different things. So I'm the pediatric plastic surgery NP at Montefiore. So if you have any questions about this or anything else related to pediatric plastic surgery, please feel free to email me. And next up, we have Dr. Tepper, who is the director of craniofacial surgery at Montefiore.
Elise, can you hear me?
Yeah.
Okay, good. All right, let me pull up my screen. I'm going to remind everybody that you can write in questions for anyone who has any questions. And we'll try to get to those as soon as we can. Well, good afternoon. I'm Dr. Tepper. I'm the Director of Craniofacial Surgery at Montefiore. And I'm going to begin by just sort of defining what craniofacial surgery is. It's this vague term that sometimes gets thrown around and people don't really understand exactly what it means. I think in its most simple form, I like to think of it as Mr. Potato Head. We are surgeons who put people back together, children and adults, and that goes anywhere from the head to the toe and throughout the body. Now, the types of patients who come to us as craniofacial surgeons is a range of either congenital pediatric patients, but it can also include trauma, cancer, etc. And let me make a plug for our craniofacial program at Montefiore. We are one of the first, if not the first in the country. And that predates me by many decades. But I've had the fortunate opportunity to be a part of it and help lead that team over the last 10 years. Now, I know we're focusing on skull shape, but I just want to give you a little snapshot as to what sort of a typical day at the craniofacial clinic might look like. And just to show you the breadth of patients that we see, anywhere from infants to teenagers, adults, burns, congenital defects, syndromic situations, any facial deformity, we treat those types of patients here at Montefiore. We do things that most of you are familiar with, but things that you see probably much more commonly is cleft lips and palates. We have a robust ear reconstruction center where we build new ears. In this case, a kid who needed a complete reconstruction. And then things less severe, like a child who may need their ears simply just pinned back for prominent ears. And then more recently, we're seeing more and more infants who are born with slight deformities where we can do molding of the ear to help get that into the appropriate shape and avoid surgery down the road. All right, so let me focus on craniosynostosis, which is what the goal of today's CMA is going to be. And this is the patient that Elise showed earlier. And just to kind of go over again, now that you've had a sense of the diagnosis, we're looking at a right-sided unilateral coronal synostosis. So the forehead here is set back. There's some prominence on the contralateral side. And here you are seeing the view from below. Here we are looking at the CT scan and the patient from below. So how do we fix this surgically? Well, in a case like this, we do what's called a fronto-orbital advancement and a cranial vault remodeling. And what does that mean? Well, it means reshaping two parts of the skull. Part one is going to be the forehead and the cranium that's affected by the suture. And in addition, it's going to be the bandeau. So the fronto-orbital portion of this involves this. This red outline shows the frontal bone that's going to come off and be reshaped, okay, to an appropriate skull shape. And the second part of that operation is shown here in yellow, which is the bandeau. And what the bandeau is the bone that extends from below the brow across the bridge of the nose. And that's affected by craniosynostosis as well. So it's going to, what we do to surgically correct this is going to involve both fixing the skull as well as that upper portion of the bandeau. Our technique is something that we described many years ago. And what we do is called the suture lattice technique. So these are schematic drawings of how we approach this surgically. On the bottom left here, you're looking down at the skull from above. You're seeing the suture, rather the fontanelle here anteriorly. And this dotted line represents where we're going to make those cuts in the skull. And we're going to take here in the back right, you can see an ideal shape for the forehead. We have a template that matches the shape of what a child with that of that age would have for a normal forehead. And we're going to use that piece to then recreate the forehead. We're going to use a central piece of bone that's going to protect the sagittal sinus. And then the remaining parts are going to be put together essentially like a jigsaw. We're going to take shapes of bone and ideal pieces that begin to shape a more rounded skull. And here you could see that front view, which is showing the new forehead and the bandeau placed. Now, how do we do it surgically? I'm going to show you here in this drawing, and what this is called is a coronal approach to the skull. And this is the schematic here is shown in adult, but what it involves is an incision in the hairline, and then having to bring all of that scalp and forehead down so we can access the areas of bone. All right, so this is my graphic disclosure for those of you who may not feel comfortable seeing things in the OR, but I'm going to give you just a couple pictures of what that looks like. Here we are in the operating room and we're looking down at this child's skull. You can see the fontanelle. This is that patient in CT scan you saw earlier. The right side is set back. The left forehead is forward. This blue line represents the new forehead that we're going to recreate. And here we are in the operating room. On the top, you're seeing those schematics from our initial description and paper, matching or correlating to those bottom photos. This is what the patient looked like on the table. This is what the patient looked like at the end of the case. New forehead, new central piece of bone, and all these pieces put together within our suture lattice to recreate a more rounded, appropriately shaped skull for a patient of that age. And then the forehead and the bandeau construct, you can see here in the middle, which is then put in and reconstructed as shown. Here's that patient before, here's that patient early post-op. You can see the immediate effect and impact, the immediate result, the rounded forehead. We've taken care of both the prominence as well as the area that was deficient. And here she is some years later after that reconstruction. Now, Elise alluded to this, but I just want to really reiterate the importance for families to know the difference between syndromic and non-syndromic. We're talking about two very different populations of people. For isolated cases of craniosynostosis after surgery, that should be it. That's all the surgery and care they're going to need for this at all. In the case of syndromic craniosynostosis, there's often other medical issues that need to be addressed down the road. Just to give you a sense of what some of those might be is in syndromic cases, we commonly see not just fusion of the skull, but we see a stunting of the growth of the midface of the skeleton. And you can see this patient here who's got that sunken in appearance to the midface, but also leads to not just functional and cosmetic concerns, but in this case, she has a tracheostomy due to the collapse of the airway behind that retracted midface. So in those cases, we do what's called a Lefort 3 advancement. And this is an example of how that patient did with the Lefort 3 advancement. You notice a couple things. Clearly, the appearance looks better, but other things that it treats is the airway. In this case, you can see that tracheostomy, ultimately, it was able to be removed due to the advancement, and a much healthier child now who's not struggling to breathe and has the ability to thrive. Here's an older child. In this case, you can see some similar features. You also see the exorbitism, the prominent eyes, and it can be treated with advancement. Now that device in the middle is what's called an external fixation device, a distraction device, and that's used to bring that part of the skull forward. Many programs around the country still use that. One of the things we do at Montefiore is we don't use that device. We use something that's certainly a lot less scary for patients and families, which is an internal device. So it's buried. And it does involve slowly turning the device to allow that midface to come forward. But I'll show you, for example, in this patient who also had retrusion of his midface, that you can see in this picture right here above the ear, that's the titanium of the device that's buried. So we simply just turn that and at 1 millimeter a day, and we can bring the midface forward. And you can see the improvement aesthetically, as well as now being able to have coverage, appropriate coverage of the globe and the eyes as well. The last thing I want to touch on was just something I'm fairly passionate about and is a pretty robust aspect of our craniofacial program, which is innovation and technology. And I'll just briefly touch about some things, some ways that we're incorporating this technology in the operating room today. This is not futuristic. This is really present day innovation. Now, as many of you know, we had been involved in a separation of craniopagus twins or conjoined twins a number of years ago. And this was the kinds of technology that we had used in the operating room, 3D printing of the skull, of the brain, and you can see how helpful that technology was. But my point in showing all of that technology is not to say we're using it for these uniquely complex cases. We're doing this day in and day out. This is really a routine and standard aspect of our craniofacial program, and we're doing it in many cases for craniosynostosis. I'm happy to say we now have an in-house 3D printing lab, which allows us to not just rely on industry partners to be able to incorporate this technology, but we can begin to do it in-house. Again, I'm going to show you an intraoperative photo here, but this is an older patient requiring skull reconstruction. You can see just how valuable it is to have an exact match of the patient's skull next to the actual patient, just for an understanding anatomically, surgically, to be able to identify things three-dimensionally. In space, virtual planning and simulation is a really important part of what we do. For many of these patients, we're planning out the surgery first on the computer. So we're going to identify any problems that we may incorporate or may face rather, but we're going to do it first through a simulation rather than find that or address that or face that in the operating room. And then the last thing, which is on the horizon, is the notion of augmented reality. And I'll just show you some quick examples of this. So this is, here we are in the operating room. We are looking through a augmented reality device. What we're seeing through that lens is what you're seeing here on the screen, which is the ability to have CT scans and medical information available to us in the operating room during surgery. So we can then draw upon that information during these procedures. This next slide here, I want to show you is an example of an actual patient with craniosynostosis. You can see here the twisted skull, that's hovering above the patient during the reconstruction. So we have that as a reference to see and compare to how things appear in the operating room. And then lastly, sort of the new frontier of this is saying, well, this is not just helpful for some of the bony reconstruction, but some of the soft tissue. And so here what you're seeing is an augmented reality hologram. And what we have now the ability to do is not just put that in space, but begin to manipulate it. So here we are moving it over to the, in this case, our patient, and be able to look at how those things can be used and applied in the operating room. When we're not using it in the operating room, this is how I got my son to say dad first, so I could be home when I actually wasn't. So it's got lots of uses. So in summary, skull abnormalities, they represent a wide range of diagnoses. And as we talked about, but again, really just to hammer this home, the importance of syndromic versus non-syndromic, two very different conditions. In the case of plagiocephaly, again, there's deformational plagiocephaly, which is a positioning problem, versus something that's due to craniosynostosis, two very different treatment paths. And even within patients who have craniosynostosis, the treatments vary greatly. It's not always the surgery I showed, which requires the whole reconstruction with a suture lattice. There are other situations where less invasive procedures are amenable, or simply just shaving or reshaping of the bone. Again, our program, we have a rich history. We have lots of experience treating these and related conditions, and we really want to be a resource for physicians and physician extenders, as well as families. And then lastly, I'm just going to put my email up. If anyone has questions or wants to reach out at any point for any assistance, feel free to reach out. Thank you. So, Dr. Kobetz, you're ready to go?
Mm-hmm.
All right.
Give me 1 second. Thank you very much, Dr. Tepper. Hopefully everybody can hear me. I'd like to talk about the state of technology in craniosynostosis management. Some of the newest innovations being utilized at our center as one of the leading centers in the nation for these types of repairs, as well as some of the other work at different centers, creating animal models, understanding the genetics behind craniosynostosis, and then taking a step further, how we're integrating technology in the operating room, as alluded by Dr. Tepper, and I'll take it a step further in terms of how we're optimizing our reconstructions for our patients. So just very briefly, we discussed many times that craniosynostosis restricts the normal growth and development of the brain with asymmetric cosmetic deformity that contributes to poor psychosocial outcomes in children. It's associated, as we discussed, with nearly 180 congenital disorders and 50 nuclear genes that influence premature suture fusion. However, as we said as well, there's a majority of cases that are non-syndromic that result in fusions as well, that we are understanding the genetics for as well in the current state of the literature. Surgical correction, either total cranial vault reconstruction or open or endoscopic suturectomies, are the mainstay of treatments currently and corrects this cosmetic deformity. And really twofold paths that our advancement of our understanding of these disorders have taken recently. One side is understanding the genetics and creating animal models that I'll discuss very shortly. And the other side is really the optimization, or the digitization, I should say, of intraoperative correction has really been the focus to minimize intraoperative interpretation, minimize this art form, which we do very much like as surgeons, but it provides us with a greater sense of comfort knowing that we've reached our aesthetic goal and our reparative goal for our procedure immediately within the surgery. So first, I'd just like to touch on some animal modeling, some epigenetic and genetic contributions that have recently been made in the literature. We talked about the big five, usually the big three syndromic causes of craniosynostosis with Cruzans, Apperts, and Pfeiffers, but monkeys and C3-Chotsins we should also consider. And a lot of these involve, at least for the big three, fibroblast growth factor receptor abnormalities. And I'll go into the next slide in terms of some of the specifics, but really the fibroblast growth factor receptor, we've understood that there are genetic abnormalities that cause the malfunctioning of this protein that we're working currently to unlock. And with C3-Chotsins, in terms of how twist gene abnormalities result in the coronal synostosis seen, we're understanding much more and understanding greater detail in terms of the molecular results and consequences of this gene abnormality. So very briefly, Cruzans is the result of a cysteine to tyrosine mutation on the fibroblast growth factor receptor 2,3C isoform. It causes the syndromic shortened faces, dome-shaped skulls, and it results in increasing numbers of osteogenic progenitor cells within the skull vault. Apperts, we've understood to be a serine to a tryptophan mutation on fibroblast growth factor receptor 2 gene that does similar present with a dome-shaped skull, mid-face hypoplasia, and syndactyly due to upregulation of this receptor. Pfeiffer's is a proline to an arginine mutation on growth factor receptor 1, which causes this multisutural fusion by day 21 without any effects on the skull base or the long bones, and it's really a result of impaired osteoblast proliferation and differentiation. C3-Chotsins, which I'll have a little bit more detail on the coming two slides, is this twist gene knockout, and it really results in this premature, specifically coronal closure as a result of endochondrial ossification. And as we start to unlock a lot of these mutations, we understand why these abnormalities are occurring, and it provides us with a medium and a target through which we can intervene. So on the right side of the image, as dictated and regulated by growth hormone, IGF-1 is able to bind to its receptor on the cell surface, which then activates the PI3K-AKT pathway, which then phosphorylates, inactivates GSK-B3 and twist, which then provides for RUNX2 and beta-catenin to be activated and to provide transcription of osteogenic genes. So without the inhibition, as seen on the left side, of the twist1 gene and protein and the GSK-B3 protein and gene, these RUNX2 and beta-catenin proteins are able to cause craniosynostosis by having an unchecked transcription of osteogenic genes. And only when these inhibitory factors, normal inhibitory factors, are present, we then prevent the expression of a craniosynostosis picture. So understanding more of these genes in terms of the pathways involved in their protein products, normal function and abnormal function, allows us greater insight to then be able to create animal models. And as we've seen here, with a heterozygous knockout for a twist1 gene on the top right image, we can start to see a unilateral coronal synostosis similar to what patients with, say, Streiff-Chosin syndrome will see. And on the bottom two panels, we can see that combining this twist gene heterozygous expression with either GSK3B heterozygous expression or IGF-1 heterozygous expression results in the presentation of these phenotypes in mice. Utilizing this technology in the future will allow us to understand how to intervene and potentially prevent the presentation of these abnormalities without the need for surgery. So that's just on the horizon from a genetic standpoint and animal model standpoint. And really, these animal models will allow us for greater understanding of this premature closure, in-depth evaluation for changes in osteogenic precursors, and provide targets for future therapeutics. Even further, epigenetic causes, in addition to the gene mutations in non-syndromic cases, are currently being evaluated in order to advance our understanding of these disorders as well. So that's going to be on the horizon currently, and many therapeutics, I believe, will be produced as a result of understanding the molecular basis of these abnormalities greater. Next, I'd like to move on to what Dr. Tepper also touched on, using 3D modeling or stereolithography for the either proposed plan for reconstruction to show the parents preoperatively, to either demonstrate the cranial malformation to them without having to use a virtual model, but having something physically in their presence to be able to look at, and then being able to print and using 3D models to then demonstrate what our proposed repair will be intraoperatively. Now, this planning, not only of a hard model, but also virtual planning, will allow us to then create and plan for all of the bone reconstruction that we will perform in the operating room, which will decrease our anesthesia time, decrease our blood loss, and optimize the OR time with much greater comfort for the surgeon that our goal was achieved. And I'll talk about that in much more detail in terms of the way that we're leading the charge as a center of excellence for this kind of intraoperative, preoperative, and postoperative evaluation of our reconstructions. Finally, this eases the anxiety of parents. It's been shown that providing these models, these virtual or hard models, allows the parents to feel much more comfortable with what they should expect post-procedurally. So this is kind of where we started. We obtained CT scans for our patients. We have a metopic closure here that's readily evident. But we started with our CTs that would provide us these static images for these virtual models. And the next step was then to print these models. We were able to provide some degree of understanding of what the calvarial structure is under the soft tissue of the skin for the patients and parents to understand what the deformity is, and then be able to create models in terms of what the reconstruction will plan to be during the procedure. So that was kind of the next iteration. And, you know, they can get quite detailed. And, from a screenshot here of some of the models that we use to explain the separation of the McDonald twins, they can get quite lifelike and can really help parents understand what's going on. Then the next iteration of that is a virtual planning of virtual models to then be able to allow us prior to the operating room to understand all of the bone cuts, the osteotomies that will perform the reconstruction of all the bone pieces in the exact position that we hope to achieve in the operating room, to then provide an exact picture of what the reconstruction will entail for the patient and the parents post-operatively. And this has been wrought throughout the literature in a number of different centers in the last couple of years, including ours are leading the charge in this kind of approach. And really, I found this quote that really sums up nicely that this computer-assisted surgery is revolutionizing the surgical approach to complex, as well as even easing the management of less complex repairs. We need to consider that these computer-assisted surgical tools will change our surgical practice, but not supersede it, that the surgeon can rely on this information, yet nothing will replace his or her eye and experience. It is the combination of both this experience and the appropriate use of this computer-assisted surgery that ultimately will lead to a successful surgery for all of our patients in the future. Now, I just want to discuss a little bit in terms of how we're then leading the charge in regards to not only providing these models, but then to evaluate intraoperatively whether our reconstruction in real time for this patient is meeting the goals that we are looking to have achieved based on our preoperative models. And I can jump over very briefly to a video that we actually recently had accepted to Neurosurgical Focus, where we describe our technique that we're using at Montefiore Medical Center that Dr. Tepper, that Dr. Goodrich, and that Dr. Abbott have been working on for quite some time. Here we have a patient of a unilateral craniosynostosis that we're, in terms of our preoperative planning and in terms of what we're planning intraoperatively. As discussed before by Dr. Tepper, we're elevating the skin very carefully. We're very careful to preserve and elevate the periosteum here, which will provide the blood supply to then allow all of our sutured lattice pieces of bone to then get the blood supply to be able to regrow into a solid calvario closure at the end. Here we're using a Marshak template to outline our forehead piece for the reconstruction. We're very meticulously and carefully making our burr holes to then be able to provide undermining of the dura off of the bone to then create our calvarial osteotomies and to create our craniectomy to be able to entirely remove the piece of abnormal bone that's growing on the patient's head. Here, we've now prepared the portion of the frontal bones to be removed for Dr. Tepper to come in and for him to be able to do the osteotomy of the orbital bar that we're shown taking off right here, which will allow us to complete our frontal orbital repair. Dr. Tepper working to mold pieces of bone and then demonstrating here what our new forehead will look like. And then, of course, create our lattice network to then create an idealized contour to the patient's head. And then, of course, to close our periosteum back over to provide a nice outcome for our patient. That's our approach. This is something that we've been explaining for many years, and recently, I've been able to provide videos for other centers to be able to model in the future. We've also had a couple of advances in terms of our ability to provide a greater evaluation of our correction intraoperatively, and we've been leading the charge in this in the literature. This was a paper from Child's Nervous System in the last few years. After our virtual modeling preoperatively, we then perform our reconstruction in the OR, as seen on the previous video. We use intraoperative imaging that we have in our operating room to then be able to generate an actual image of the patient on the operating room table, and then on the top panels of A and B here to overlay, which is the green section, what our preoperative plan for the reconstruction for this patient would be. We can compare exactly what we're seeing in the OR overlay it in real time into what our preoperative plan would be to demonstrate whether we're achieving the contour and the goal of a surgical correction or not. And on the bottom panels, we were able to use this technology to show that there were a few fragments that were misplaced that needed to be corrected in order to provide the optimal outcome for this patient and to be able to provide a better recontouring of their head. And, patients, we've been using this intraoperatively, and we've had excellent results. This patient from the original patient that I showed for the metopic correction, really excellent results by even being able to use intraoperative information to then show before even closure of the case that we've met our preoperative goals. Then our next step, and will be the focus of a new study that we're initiating at Montefiore, will be the use of this 3D photography instead of intraoperative imaging to have real-time evaluation of what the patient's recontoured skull looks like, utilizing 3D cameras, which will provide a surface overlay for what the actual reconstruction of the head looks like, and then be able to overlay it onto our preoperative 3D photography from our patients to then demonstrate areas where we're getting in areas that are not exactly idealized to then be able to give us information in the operating room on how to optimize this. So this is really going to be the focus of a large prospective trial, hopefully a multi-center trial that will be centered at Montefiore Medical Center, where we're really going to be looking at an unblinded, open label, prospective randomized study comparing the outcomes of either suturectomy, which we provide for patients who are younger, or total calvario reconstruction that we've been talking about in great detail for our older patients, utilizing 3D cameras to provide precise metrics of head shape and comparison to standardized cranial contours, which we've been able to obtain working with Stryker and some of our other modalities and different companies that have thousands and thousands of standardized head shapes from thousands of patients that they've measured using these 3D cameras to provide real and accurate evaluation of our reconstructions to these standardized models, either intraoperatively or at 3, 6, or 12 months postoperatively. So really utilizing the state-of-the-art technology to be able to ensure that we're providing as precise and as cosmetically pleasing outcomes for our patients as possible. Of course, other outcomes will include patient and parent satisfaction, cognitive outcomes, intraoperative blood loss, operative time, and length of hospital stay. These families, of course, will be allowed to choose which either complete cranial vault remodeling or suturectomy they prefer, and part of this will be determined by the patient's age at presentation. We'll start with just non-syndromic single suture saddle synostosis. These patients will be recruited. If we do suturectomies, we won't use molding helmets. Our group will really aim to get 10 patients conservatively over the next 2 years, but we certainly see much, much higher volume than that. And really, this will be the first prospective trial utilizing multiple advanced optimization techniques, including 3D printing, modeling, and 3D photography to determine the difference in durable, long-term outcomes in patients compared to normalized controls. It will advance the field by determining if less invasive procedures provide similar outcomes to our total cranial vault reconstructions, and will also currently use this further refine the use of comparative 3D photography in these cases. And of course, data and workflow utilizing these 3D cameras in the OR will be applied to then all of our routine cases for craniosynostosis repair in our center. So we really do see a very bright future ahead. We thank you for joining us today. It's unfortunately being done only over a virtual format. We'd love to meet many of you and to discuss some of the outcomes that we're seeing and some of the procedures that we're able to perform for some of our very, very acute patients as demonstrated here. And of course, a talk like this would not be complete until we thank Dr. Goodrich for the work in pioneering many of these techniques over the last 30 to 40 years at Montefiore Medical Center. And it's through his work and dedication that we're able to continue the repair of patients with craniosynostosis well into the future. So thank you very much for your time, for joining us today. Don't forget to subscribe to our YouTube Pediatric Neurosurgery at CHAM page, and I'll bring it back to Dr. Abbott to provide some closing remarks.